Good afternoon. Can everyone hear me? Good afternoon. All right. I think we're going to start. It's a really great pleasure for me to introduce Dr. Babita Nag. She's the speaker today, and she will be talking on psychopathology in preschool children, the kids seen in our clinic here. She doesn't have any financial disclosure. And let me tell you a little bit about her background. You know, the thing is, this is that time of the year when, you know, our fellows, they're starting to, present, and we are thinking about transition, their graduation, moving to new places. Dr. Nag, she has been here with us for the last 2 years as a child psychiatry fellow. Before that, she is a graduate of Assam Medical College in India, and then she did a year of residency in OBGYN, and then the general psychiatry residency at University of New Mexico. Then she came to us. And she has worked very hard on her presentation, so I would let her, talk about psychopathology in preschool children. Thank you for your hard work.
Thank you, Dr. Govan. So, before I start the slides, I just want to give a brief overview of the material that I'll be talking today. I'll be talking about preschool psychiatric illnesses, their prevalence, the red flags or the warning symptoms, and whether preschoolers should be diagnosed with mental illnesses or not. And then after that, I'll be talking briefly about my research project that I've been doing here in our clinic for more than a year. So we'll start with the slides. So the community prevalence rates for any emotional or disruptive behavior disorders is around 14 to 26%. And the long-term negative sequelae are problematic peer relationships, social dissatisfaction, loneliness, increased likelihood of comorbid psychiatric disorders, and learning problems. Also, it's important to understand that, do you guys hear me without the microphone, or no? So I'll have to use it. Okay, it's kind of moving. Sorry about that. Can you hear me now? Okay. So it's also important to understand that preschool psychopathologies remain relatively stable into later childhood and adolescence. For instance, if a preschooler has been diagnosed with attention deficit hyperactivity disorder, usually it tends to carry towards later childhood and adolescence. Also, in the recent past, the studies that were done among the preschoolers, the common psychopathologies that they found were attention deficit hyperactivity disorder, or oppositional defiant disorder, autism spectrum disorders, anxiety disorders, mood disorders, and adjustment disorders. Now, the question is, should preschoolers be diagnosed with psychiatric disorders or not? And the objections are made due to the fact that preschool period is a period of rapid development, which includes physical development, neural, behavioral, emotional, and cognitive development. Also, we do not have enough evidence to validly identify and measure symptoms among the preschoolers. And the individual differences in normal development will be inappropriately identified as psychiatric symptoms. Also, the DSM approach, or the criteria that we usually use to diagnose preschoolers, does not account for developmental variation. And the young children will be inappropriately labeled with diseases that will adversely affect or shape the child's perception of self and parents or other caregivers' perceptions of the child. Also, last but not the least, the problematic behavior in very young children may reflect problems in relationships between parents and children and the wider environment, and may not necessarily be specific to the child. So the red flags or the warning symptoms that the caregivers or the teachers needs to be concerned about are things like, if a kid acts extremely fearful, aggressive towards others, is easily distracted, unable to concentrate on any single activity for more than 5 minutes, or shows very little interest in playing with other children, or refuses to respond to people in general or responds only superficially. If a child seems unhappy or sad most of the time and does not engage in a variety of activities. Also, if a kid is avoidant or seems aloof with other children and adults, does not express a wide range of emotions, has trouble eating, sleeping, or using the toilet, can't tell the difference between fantasy and reality, and seems unusually passive or experiences a loss of skills he or she once had. Now that I went through the red flags, I just want to talk to you all about a very interesting case that we actually had in our clinic here. So this kid was around 4.5 years old, of mixed ethnic origin when he came to our clinic, and actually, initially, the babysitters observed that the kid has become more withdrawn, isolative, and is not communicating with the babysitters. And prior to this, the kid was actually bilingual. He was talking in Spanish and English. So then the babysitters kind of brought this to the attention to the parents. The parents also kind of observed this, and then they decided to come here for an evaluation. Now, this case was pretty interesting because there was a sudden regression in his previously acquired age-appropriate developmental skills, and this kind of started around his 4th birthday. And according to the parents, this kind of followed after an ear infection and several bouts of high fever. So his regression actually involved various verbal and non-verbal communication skills, peer interaction, general social interactions, along with some tolerating skills. There was also some abnormal oral and motor movements, some stereotypic behaviors, and toe walking. Now, this was interesting because we could see when the kid came to us, the regression was like we could see it happening, and usually this doesn't happen when kids comes to our clinic. So this was pretty interesting. And although another important thing that we need to keep in consideration is that sometimes medical issues complicate the presentation also. So this kid was also going through some medical issues. And basically now he's being treated for suspected Landau-Kleffner syndrome, and he actually got the diagnosis of childhood disintegrative disorder in our clinic. So I just thought I'll share with you all this case because it was pretty interesting for me. Also, now we'll go to the diagnosis part. Now, it is important that we kind of diagnose preschoolers well, because we have been seeing that more preschoolers are being referred for assessment for behavioral issues, and therefore it is important that we need to know more about the psychopathologists in this age group, and also know how to diagnose them. So usually we use the DSM-4 criteria. to diagnose preschoolers with psychiatric illnesses. And there is also something called PAPA, which is the preschool age psychiatric assessment. Now, PAPA has become standard in research settings, but each individual diagnostic section can be used in a clinic setting also. And so the PAPA is a structured diagnostic parent interview, which kind of involves a range of mandatory questions and probes, and then supplemented by further exploratory probings. So now I'll be talking briefly about the research project that I've been doing for over a year here at UMC. And so the objective of the study was to describe the patient population presenting to our infant and preschool disorders clinic and reference sources, understand what behaviors are concerning to caregivers, and also the prevalence of various psychopathologies and comorbidities in preschoolers, percentage of preschoolers who follow through treatment, and also the association with preschool psychopathology with family history of mental illnesses. So the study design or the method that was used was, it was a retrospective chart review, and we kind of took all the preschoolers from the UMC 7OPC infant and preschool clinic. And the notes that we reviewed in the charts included initial intakes, progress notes, follow-up notes, scheduling forms, the CMDQs, corner scales, and also we included collateral information which was forwarded by parents and primary care doctors. Now, the characteristics of the sample is as follows. The mean age group was around 3.7 years, and the range was around 1.1 to 5. And majority of the kids were male, around 74%, and the remainder were females. And also around 58% of the kids were Caucasians, and the remainder were Hispanics, Black, Asian, and other. Also, it's interesting that most of the referrals were made by the physicians. Around 43% of the referrals came from the physicians, and these physicians included the primary care doctors, the pediatricians, and also the neurologist. There was also a good percentage where they came on their own, like around 27%. And the remainders are like speech therapist, DDD services, psychologist, and school. So the presenting behavioral concerns were categorized as follows. So kids with issues like unable to complete tasks, careless errors were categorized under inattention, and kids who had behavioral issues, tantrums, starting fires, telling lies were categorized under disruptive. And so hitting, biting, kicking, included under aggression. The mood symptoms included the low self-esteem, emotional, very sensitive. And the anxiety symptoms included were nervousness, jittery, clinging, afraid to be alone, persistent worries, and restlessness. Also, non-verbal abnormalities such as poor eye contact included. Under social, where won't play, not social, and does not have friends. And also abnormal gestures, echopraxia, hand flapping were included under stereotypies. Now, we found that around 31% of the children were diagnosed with attention deficit hyperactivity disorder, and a majority of them were males. There were around 19 males and 4 females. And also, a good number of kids, around 35% children, received the diagnosis of autism spectrum disorder. And then we'll talk later why we got this number is so high. Also, anxiety disorders were around 16, and speech delay and communication disorders were around 18. ODD and disruptive behavior disorders were around 10, and the remaining are as follows. Also, interestingly, there was one child who did not get any diagnosis, and basically this kid was brought in by one of the parent, and so what happened was that the parents were going through a difficult divorce, and one of the parents thought that the child is having a difficult time getting over the parental divorce, and so he kind of wanted the kid to get some help. So he brought the kid for evaluation, and on evaluation we found that the kid was normal. And so sometimes it's important to understand that sometimes parental conflicts gets reflected in the child. And also, so when we do an evaluation, like for the preschoolers, we not only have to have empathy for the parents, but also understand what they want and where they are coming from. Now, there were around 14 children who got the diagnosis of ADHD who had significant T-score, but there were around 3 preschoolers with significant T-score who did not get diagnosis of ADHD. And instead, they got the diagnosis of reactive attachment disorder and anxiety disorders. So it is also important to understand the context and basis of symptoms. For example, an anxious child who is restless may score high on hyperactivity and inattention skills. Also, we found that there was a good number of comorbid disorders among the preschoolers, and there were around 39% of the kids had one comorbid disorder, and 30% of the kids did not have any comorbid disorder. There were around 24% of preschoolers who had 2 comorbid disorder, and around 4% who had 3 comorbid disorder. Also, the comorbidities which are usually associated with ADHD were found to be anxiety disorders, so which included anxiety disorder, NOS, social phobia, separation anxiety disorder, and OCD. There were also a good number of kids who had opposition defiant disorder and disruptive behavior disorders. Speech delay and communication disorders were around 5, and autism spectrum disorder was around 4. Also, there were few with parent-child relationship problems, mood disorders, reactive attachment disorder, and adjustment disorder. And also, the comorbidities which were associated with anxiety disorders were mainly attention deficit and disruptive behavior disorders, which included ADHD, ODD, and behavior disorder, NOS. And autism spectrum disorders were 4. Parent-child relationship problems were 2, and selective mutism was 2. Communication disorder was 1, and neurosis was 1. Now, basically recommendations were made to follow with us for around 32 children, and the rest were evaluations only. So we actually had a total of 73 preschoolers, and out of them only 32 children were recommended to follow up with us. And the remainder was evaluations, which means like they came to us for one-time evaluation only. And out of this 32 preschoolers, there were around 62% who followed through the treatment and around 37% who did not follow through treatment. Also, we found that there was higher prevalence of family history of ADHD in preschoolers who got the diagnosis of ADHD, and also there was a higher prevalence of family history of depression among the preschoolers who got the diagnosis of ADHD. So basically the conclusion was that, so this study was done in a clinically referred sample, which means like these patients were referred to us and their problems were already identified. And also we found around almost equal proportion of preschoolers received the diagnosis of ADHD, autism spectrum disorder, ODD, and anxiety disorders. And there was also presence of high rates of co-occurring psychiatric illnesses among preschoolers. Also, there was a higher prevalence of family history of ADHD and depression in preschoolers with ADHD. So, this study done by Levine and Libelli in 2009 was done in a large descriptive, it was a large descriptive study. It was done in a community sample. And they also found that the most common disorders that were seen among the preschoolers were ODD and ADHD. Also, the difference from our study would be that our study was done in a clinically referred sample, but this was done in a community sample. And as far as I remember, it was actually kids were picked up from primary care clinics and also some pediatric clinics. And so the sample size is large, around 391 boys and 405 girls. And the study that was done by Timothy Willens in 2002, this study was done in a clinically referred sample, like the study we did. And they also found that the most common psychopathology that we see among the preschoolers are usually ADHD, and they found around 86% of their population had ADHD, of their sample had ADHD. Other disruptive behavior disorders were 61%, mood disorders were around 43%, and anxiety disorders were around 28%. Now, the limitations to the study is that our study was done, the size of the sample was small. We had only 73 preschoolers, so that limits this study. And also, the infant and preschool disorders clinic is known for its specialty in developmental disorders, and which can explain the high rate of autism spectrum disorder diagnosis. And actually, our clinic is pretty specialized for diagnosing autism disorders, and one of our major references are for evaluating autism spectrum disorders. So this is the thank you. I would like to thank all these people, and a special thanks to Dr. Guman, Jaswinder Guman. So any questions? I think I finished early. Sure. Yes.
Now I was wondering, like, there is no autism kind of diagnosis in this clinic. So that clinic more geared towards ADHD kind of patients?
I'm not sure about that, but it could be because it could be, but I'm not sure about that. But yeah, I'm not sure about that. Like our clinic, we have a like clinic for autism, you know, autism spectrum disorders, and that's why we are getting a high number of autism spectrum disorders. It is possible that their clinic is more geared towards mood disorders and other disruptive behavior disorders. But as far as I remember, I don't remember that. Do you remember, Dr. Kuman?
What I know is that this study was done in, what they did was this is a general clinic, general psychiatric clinic, both adults, older kids and preschoolers. So they just picked a preschooler sample and looked at the prevalence of psychopathology. What I'm wondering is maybe they have a separate, specific developmental disorders clinic that's separate from the general child psychiatric clinic, and that may be one of the reasons, although I don't know.
Yeah, that could be a possibility.
73 preschoolers in the study, and you referred 32 of them for treatment, and yet you clearly made diagnoses in more than 50% of the kids. So, and the other half of the kids you were just recommending watch and wait, or what happened with the kids that you didn't refer for treatment? What was the recommendation you guys were making?
So basically, yeah. So majority of the kids we recommended, but they were kids who did not follow through treatment. Also, there were a bunch of kids who were being followed somewhere else. So that's why they didn't need to follow with us. Right. So they already had set up their with someone else, and they just had come for a second opinion. Yeah, things like that. And also there were a majority of kids who had logistic issues. So then they did not follow with us. So but that's a good point. Yes, I'm sorry. Did you want to say something, Dr. Kumar?
About half of the kids we recommended they follow up with us. The other half, you said, were evaluations only. So that's so really they were, because they were seeing and being seen somewhere else, and these were second opinions. So we maybe either they continued treatment there, or we made either the same recommendations or modified recommendations. Right. But then they followed through with the person wherever they were coming from. And the second point that you made was that even out of those 32 that you made recommendations for follow-up with us, I think half of, or maybe, I don't remember, half or 1/3 of those followed, the other kids didn't. Maybe 20 followed, 12 did not follow.
Right.
And that may be because of the distance.
Right.
And where they were, and so they looked for follow-up somewhere else. It doesn't necessarily mean they were non-compliant.
Right.
It just means that they couldn't follow up with us.
Right, right.
I have a question for you on this slide right here. You're saying that 86% for ADHD. What you mean by that is, of the children that had psychopathologies, 86% of them had ADHD.
Correct.
And so here you're including your comorbidities, because obviously these are not mutually exclusive. So also, in total, out of those that had psychopathology, also had 61% had other behavior disorders besides ADHD.
Right. So this was the Timothy Williams study. That's what they found. And you're right. It could be possible that they had like comorbidities there, because 86% of the preschoolers who came to the clinic got the diagnosis of ADHD, and 61% got other disruptive behavior disorders, which means that there is an overlap of comorbid disorders.
So my question here is, how does it, okay, I'm sorry, that was one question. The other question is, so the ADHD in preschoolers, obviously if you look at the high school population or the grade school population, it's not 86%. So do you have any hypothesis as to why you kind of see that thinning out? You see the ADHD such a high percentage in the preschool population as opposed to maybe high school or older?
But no, It would not be correct to say that ADHD is high among the preschoolers and not among the childhood, the kids above the preschool age group. I would not suggest that that is what we are concluding.
Majority of them have ADHD. That's or the disruptive behavior problems and the ADHD problems are the ones that make people refer to a psychiatrist. So it's not a general population prevalence. It's really those kids those kids who came to see a psychiatric clinic.
How does that number compare to other age populations, let's say middle school, high school?
I'm not sure.
The number of 80.
Well, I think in older kids, sometimes we have to figure out the studies that have been done. There are separate clinic, let's say for mood disorders, separate clinic for anxiety disorders. So that doesn't quite tell us who gets referred. And the other thing is, in older kids who have ADHD, actually many of them are treated by their pediatricians. For preschoolers, pediatricians don't always feel comfortable treating them, and so that's why they refer more of the ADHD preschoolers to psychiatrists rather than treating them. So that may also skew what's the percentage.
I don't know if your question was like in the middle, like the regular middle school, what percentage of kids have ADHD? Is that?
Yeah, so that number 86%, if you were to change the population from preschool all the same qualifications, and instead of looking at preschoolers, look at middle school or high school, how does that number change, or does it change?
I mean, I would like just when they were saying these are more clinic kind of patients, but if you look at the general population, I mean the kids, about maybe 4 to 6% have ADHD. If you go to any high school, middle school, that's where you see that.
But even in a clinical population for older kids, there is a higher percentage of kids with ADHD, but then as you get older, then there is more depression also. So I would say, I don't know, I'm not off the top of my head, I can't see. Remember, there is a clinically, a study done in clinical population, but I would think at least 50% of the kids have ADHD, 50 or more have ADHD.
But I have mentioned here, like in one of the articles, they have said that if the preschoolers have been diagnosed with psychopathologies, they relatively tend to be stable when they have like adolescent or even childhood. So they tend to remain stable. So we can make an assessment from that they continue to have the issue.